pleasure, right, to introduce Dr. Ruth Sapir-Pichhadze to join me up here and present on her topic, Pathway to Implementing Molecular Compatibility in Organ Allocation. So Dr. Sapir-Pichhadze is a clinician scientist at McGill University Health Center, an associate professor, specializes in nephrology and transplantation. She trained at the University of Toronto, completed a Ph.D. in clinical immunology, focusing on antibody-mediated kidney transplant injury. Her expertise includes pathogenesis, diagnosis, and prognosis of anti-HLA antibody impacts. Ruth.
Thank you so much. Thank you for the introduction, and thank you, CDTRP, for the kind invitation. What I'll share with you today is work that has taken place over the past few years, and at least for me, was started out thanks to support from CDTRP. So these are the funding organizations that allowed us to pursue this work. So all of this work commenced actually with the understanding as a transplant nephrologist on the advantages of kidney transplantation. So certainly kidney transplantation in comparison to dialysis offers improved survival, quality of life, and to the healthcare system, decreased healthcare costs. However, we do struggle on an ongoing basis with the outcome of graft failure. When it happens prematurely, certainly it contributes to, unfortunately, decreased patient survival, decreased quality of life, as well as an increased burden to the healthcare system. One of the strategies that we are pursuing as a community to try and inform ourselves on underlying immunological risks is to verify if transplant candidates have preformed antibodies. Related to the repertoire of preformed antibodies a given transplant candidate might have, there is an associated implication to patients being able to access transplantation. I don't think it's me. Okay, thank you. So whereby patients who have no preformed antibodies will be eligible to receive a donor from the entire donor pool. But the more the higher the repertoire of anti-HLA antibodies, there's a decreased capacity to access transplantation. And this was demonstrated in this analysis we pursued looking at PRA and access to transplantation. The higher the PRA, and notably in those with PRA higher than 80, the access to transplantation is diminished. No less important is the fact that while waiting for transplantation, patients are also at increased risk for mortality. So here, the representation as a function of increasing PRA. I think this should be directed in a particular direction. Otherwise, I don't think it's responding to me very effectively. May I ask for help? Sorry? Towards you. Okay. Nope. Okay, I'll try now. Once, twice, no? The big button. Yep, the big button doesn't want to move. Okay, it moved, yes. Okay, so now that the big button is moving, so I will move on to my next slide. So with this, we are trying to do better for our patients. So the issue is that preformed or absence of preformed anti-HLA antibodies does not preclude new antibodies from forming, which opens up a whole opportunity to try and inform our care, relying on compatibility between donor and recipients at the molecular level. I will elaborate on this shortly. I will also share with you a pathway to incorporating molecular compatibility into organ allocation schemes in an effort to prevent immune-mediated injury, not only explain preformed antibodies, but also prevent those from developing. And finally, I'll show you some tools that we've developed that hope would be useful for the community as a whole. Again, it's not working, so we'll try again. Okay, very good. So moving on to the next slide. It's good. I was told there was a little bit of extra time, so we can afford this. So I'll try to move faster though. So can molecular compatibility assessment better inform immunological risk? So the idea is that molecular compatibility, again, by informing not only the presence of antibodies, by allowing us to, with greater sensitivity, inform ourselves with regards to the likelihood of developing antibodies, allows us to modify from looking at the donor pool as grain, those who have no preformed antibodies. So each donor represents a similar immunological risk moving forward or allowing access to transplantation. Accordingly, using molecular compatibility, there's a more greater appreciation of risk in a more granular fashion given any particular donor that is coming forward. So what is molecular compatibility? So if you were to look on the left-hand side, we have a representation of multiple anti-HLA alleles. So when we are considering the repertoire of amino acid sequences that each of one of these genes informs, you can see that in comparison to HLA-A0101, this serving as a consensus reference, subsequent HLA-0201 and others have largely homology. You see it as a hyphen in the sequence of amino acid representation below, but there are some locations that are polymorphic, where there's substitution of amino acids. And when these structures inform or are present at the surface of HLA antibodies, a scientist called René de Quesnoy envisioned that they may be accessible to antibodies, induce an antibody response, and interact with antibodies to result in immune-mediated injury. Now, this algorithm that René de Quesnoy developed, again, envisions or tries to predict polymorphisms that would result in anti-HLA antibody development. And the literature has in the literature, multiple groups have pursued effort to lend support to this algorithm actually representing a biologically relevant structure. And to do so, there has been curation of antibodies that were attributed specifically to incompatibilities at those at the level of those polymorphisms, which in René de Quesnoy's nomenclature are referred to as eplets. So on the left-hand side over here, you see an analysis that we did with the Scientific Registry of Transplant Recipients, wherein we looked at increasing numbers of molecular mismatches and their implication to death-censored graft failure. On the right-hand side, you see an analysis that we pursued using a retrospective cohort from University Health Network, in which we pursued a nested case control study where cases were defined as patients with transplant glomerulopathy. So starting from molecular incompatibilities, informing the development of donor-specific antibodies, and thereafter irreversible immune-mediated injury and final graft failure. So for these two outcomes, we were able to demonstrate that the greater the molecular incompatibility, the higher the risk of experiencing these outcomes. And when we looked at the subset of antibody-verified eplet mismatches, the risk was quantitatively greater. With this knowledge comes the following question. So when we are considering cumulative molecular mismatch, so each additional mismatch is associated with an increased risk, we're effectively assuming that all of these mismatches are equally important or equally likely to result in an immune response, development of antibodies. But that might not be necessarily the case. Now, the best way to address this question is to make sure that we have a context where all molecular incompatibilities are present, and we give every one of these incompatibilities a fair chance to demonstrate development of antibodies. So to do so experimentally is clearly challenging. So what we did, we leveraged the strength of a large administrative database, the Scientific Registry of Transplant Recipients, and pursued a data-driven approach where, in collaboration with the National Marrow Donor Program, we used serologic HLA typings to infer allele-level typings, and thereafter, from these allele-level typings, we're able to inform the sequence of molecular incompatibilities observed for each donor and recipient pair. Thereafter, we tried to look at individual mismatches and their association with the risk of death-censored graft failure. There were 412 such eplets. The subset in this initial analysis that were antibody verified were about a third of those. But you can see that some non-antibody verified eplet mismatches were also associated with an increased risk of death-censored graft failure. Thereafter, again, trying to verify which of these mismatches are most predictive of the outcome, we subjected this entire data set, after splitting it into 2/3 and 1/3, to a lasso procedure that selects the most predictive mismatches. And there we found a subset of 55. Of those, 15 were validated in the remaining third of the cohort. All of these trying to outline which are the most important mismatches to consider and avoid at the time of organ allocation. Now, importantly, I'm showing you this slide to focus on the right bottom hand of the slide. When we are identifying high risk incompatibilities, it is important to address the concept of confounding. And in the context of HLA, you saw in one of the original slides that I showed you that certain mismatches multiple mismatches could appear in relation to particular donor and recipient HLA types. And so any mechanism whereby we are considering a particular mismatch as a predictor of the outcome of interest, it is important to recall that it might not be that particular mismatch, but the company that it keeps, as those mismatches could travel together with multiple ones appearing in rather than the one selected, an alternative one could inform the risk. And so to illustrate for the next steps of experimental verification, what we should be pursuing when we're identifying such high-risk incompatibilities, I want to share with you the concept of a profile. So a complex of molecular mismatches that could travel together. So if we were to start from the top with haplotypes, each of us has 2 haplotypes to yield a genotype, and we can transform that haplotype to the eplet or molecular compatibility realm and inform ourselves on a sequence of eplets that each particular patient may have. When comparing the repertoire of donor eplets to the recipient eplets, if a donor has an eplet that the recipient doesn't have, this would inform a mismatch. So when we take the combination of mismatches between donor and recipient, we can subject those to an analysis called weighted gene correlation network analysis and identify those mismatches that tend to travel together. And what we observe, not surprisingly, I would say that some HLA class 1 eplet mismatches travel together, other HLA class 2 mismatches travel together. So again, it's important to acknowledge this when informing risk. Number one, it's also bringing an opportunity to improve compatibility. So in the literature, those who are pursuing or who are following this literature would see different strategies of molecular compatibility that people might have looked at. So we have class 1 and class 2 HLA, and the literature largely focused on class 2 mismatches, given more frequently we observe antibodies against class 2. There are subsets of antibody verified, as I showed you. And we've also identified through the data-driven approach a subset of mismatches that appear to confer greater risk individually. So what are the implications of all of these strategies when assessing molecular compatibility? So on the top left, epitype, looking at class 1 and class 2 mismatches. The second bottom on the right, class 2 antibody verified eplets. So sequentially, these representations show you a smaller and smaller number of mismatches that could inform the risk of graft failure. Across these figures, what we see that the higher the mismatch load, the lower the graft survival or the higher risk of graft failure. Now, this representation is informs the risk of graft failure in patients who are of a distinct type. So we can plot those for each patient characteristic or a base case in a population. So these relate to a male who is, let's say, 30 years of age on public insurance in the US, who has waited on dialysis for 21 months, received a standard criteria donor transplant from a male donor after 11 hours of cold ischemia time, and was induced with an IL-2 receptor blocker with maintenance immune suppression on tacrolimus and excluding steroids. So these would be the plots considering the various molecular incompatibility strategy informing their risk of graft survival. But importantly, when you're taking into consideration the molecular compatibility, a different patient in a context of a particular donor and in a context of a specific transplant experience could have a different risk of experiencing graft failure. So in addition to whatever risk we saw related to molecular compatibility in the base case, if the recipients are younger, their risk, as you can see with the hazard ratio to the right of the 1 value, are at increased risk of experiencing graft failure. Similarly, those who are not on a calcineurin inhibitor-based type of protocol are at increased risk of experiencing graft failure. On the other hand, I mentioned the base case was not on a regimen including steroid supplementation of prednisone as part of the maintenance regimen could diminish the risk. So you can see that there are opportunities to modify potential adverse outcomes given molecular compatibility, but in addition, there are contexts where you want to prioritize molecular compatibility or can taper the management that is administered to modify the adverse outcomes. So from here, I want to share with you, as we embarked on this Genome Canada project that allowed us to pursue this work, a roadmap for incorporating molecular compatibility in organ allocation schemes, having shown you the potential implications to outcome of molecular incompatibility. So to pursue this kind of, or to incorporate molecular compatibility in clinical practice, first we need to make sure that we have unambiguous HLA typing at the allele level, and that it would be available in a timely fashion for the donors, in addition to the transplant candidates. The concept of EPLETs, the antibody verification, there have been various iterations thereof, and there was an effort that was starting around the time we embarked on this project to try and standardize the nomenclature with this regard. This is an ongoing effort. Then it is important to determine priorities for matching, identifying high-risk incompatibilities, and also verifying that we can actually try and match on those. If you reflect on this, there's a few hundred of mismatches that we might want to diminish in this context. But as mentioned, it may be that not all of them are equally important to try and optimize. So how can we inform ourselves on the priorities for molecular matching? So what we did, rather than relying just on the development of antibodies, because although this is an important outcome, some antibodies do not result in tissue level injury. So we focused on the outcome of antibody-mediated rejection that often starts with development of donor-specific antibodies. There's complement activation, microcirculatory inflammation. When these events are short-lived, they could be reversible. But if they're going on for a protracted period of time, that they can result in graft dysfunction and eventually graft failure. So the classification that we relied on as we were embarking on this project was the Banff 2017 classification. To study this, we needed to make sure that we have sufficient power to answer the questions of interest. We collaborated at a provincial and national level, complementary to that, to yield the number of antibody-mediated rejection outcome events. Now, we needed to standardize the diagnosis that otherwise would have spanned a period of about 10 years. And if people are familiar with the Banff classification, you know that over the past decade, every couple of years, there's some kind of modification in the classification. So much effort has taken to make sure that that happens. In addition to the courtesy of pathologists and colleagues from across sites for this analysis in Quebec, we also developed an algorithm that allowed us to assign the diagnosis in a standardized fashion. This algorithm is available on CRAN for people's reference and free use. Now, I mentioned to you that we need allele level typing to inform molecular compatibility. I would say we need high resolution HLA typing to inform at this level, and why. Very succinctly, I will have you focus on the letter at the right-hand side. Not only do we need to know the allele type to inform the HLA molecule and the molecular or the epitype, the fact that some alleles do not end up not being expressed effectively, if you reflect on it, if they're not expressed in the donor, that diminishes molecular incompatibility. But if they're not expressed in the recipient, and there might be some sharing of applets, it actually underestimates the molecular incompatibility. So this level of information is important to acquire. Again, in parallel to this project that has spanned the past several years, also efforts have taken place to very carefully curate the antibody verification process. So thanks to the efforts that have taken place at Leiden at the time, the whole HLA at the time epitope registry underwent extra validation with regards to the antibody verification. And in the analysis I'm sharing with you, we focused on the subset that were antibody verified, but based on higher quality data. So high resolution HLA typing, as well as solid phase assays. So this is the subset that we relied on for this analysis. We looked at the relationship between molecular incompatibility and antibody-mediated rejection across its continuum with design that is more efficient. And that design is called a nested case control study. Rather than studying the whole cohort, we can efficiently inform ourselves at a similar, in a similar fashion on the time to event of interest, antibody-mediated rejection this way. And here I'm sharing with you the subset of cases and match controls that were typed by next generation sequences, and so were their donors. So a graduate student working with me pursued this study, and we evaluated the risk of AMR from all applet mismatches on the left top-hand side to the subset on the right-hand side of class 2 Leiden antibody verified applet mismatches. We conducted conditional logistic regression analysis, and to inform ourselves on a threshold of molecular incompatibility beyond which the risk of AMR was greater, we used restricted cubic spline transformation. So very succinctly, what we see in these analyses at the very bottom of this table, that the subset of class 2 Leiden antibody verified applet mismatches were associated with an increased risk of AMR, whereby each single applet mismatch falling into this subset increased the risk of AMR by 15%. And this is in the context where we account for patient, donor, as well as transplant characteristics, induction, as well as maintenance, immune suppression, and how it varies over time post-transplant. When we were looking at the thresholds beyond which the risk of antibody-mediated rejection may increase, on the left-hand side, we're looking at the outcome of antibody-mediated rejection across its continuum. On the right-hand side, the subset of confirmed AMR events. Now, you might ask, why did we look at AMR across its continuum. If people are aware of the iterations in the recent BAV classification, there is increasing appreciation that microvascular information might not be the practical synonymous of antibody-mediated rejection that it has been used as in passing years. Also, it may be that the assignment of DSA historically might not be consistently assigned moving forward. So we wanted to make sure that we are sensitive in including cases of antibody-mediated rejection, but also sensitive in ensuring that controls are not misclassified as such. So what we observed, so if we were to focus on the class 2 Leiden mismatches, so we saw that beyond 5 Leiden antibody-verified eplet mismatches, the risk of antibody-mediated rejection increased. Now, we can use this information moving forward. So rigorously, antibody-verified HLA class 2 eplet mismatches are independent predictors of antibody-mediated rejection, and minimizing molecular compatibility at the time of organ allocation could mitigate AMR risk if we were to prioritize it. So before continuing with modifying organ allocation schemes, there's obviously concerns when you're reliant on a parameter that we appreciate some members of the population might be vulnerable to have somewhat diminished access to transplantation as a consequence of. We wanted to make sure that we have buy-in from the public as we pursued this endeavor. So for this purpose, in collaboration with a team at UBC, we conducted a public deliberation. This is often pursued when we have a context where a resource is in demand but scarce. And again, there's complex decision-making that needs to be taken into consideration with values of individual patients that one needs to be sensitive to. So in that process, we recruited from across the country. There were efforts to enrich recruitment of particular populations that are whose input was of considered to be of importance. And with that effort, there was quite a diverse group of people from a self-reported ethnicity perspective, age distribution, education, and employment type of context to inform our public deliberation. We asked the participants 2 key questions. The first being, how could, at the time we were referring to it as epitope compatibility, be implemented in a way that is fair for transplant candidates. And here there was openness to pursuing molecular compatibility, albeit understanding that there might be inequities that would arise, but there was also appreciation of the issue, less so of waiting time, but most so of medical urgency. So if someone is imminently in need of a transplant, that they should not be compromised, but otherwise there was openness to this concept. When we asked what are important considerations in the way kidney allocation policies and decisions are made, transparency was deemed important, but also reevaluation of the policy once it's implemented. So at an interval of 5 years, we were encouraged to reevaluate the outcomes of changes in policy with this regard, but also flexibility was highlighted, again, considering the issue of medical urgency not being compromised for the benefit of longer-term utility. So with this encouraging note from the public, the work continues. So here I'm going to share with you some analysis that we pursued on feasibility of incorporating molecular compatibility in regional organ allocation schemes. So we wanted to verify whether HLA class 2 molecular compatibility can be optimized regionally. Again, this is how our organ allocation happens in Canada, albeit in the era of molecular compatibility, we are striving to inform a practice nationally as well. And so we wanted to evaluate additionally, what are the implications of prioritizing molecular compatibility in organ allocation on access across potentially vulnerable groups. So for this, we conducted a simulation in a retrospective cohort from Transplant Quebec from 2016 to 2019, where we had molecular typing to inform the molecular compatibility. We verified the molecular compatibility between the current organ allocation scheme applying the Transplant Quebec rules versus a scheme that prioritizes molecular compatibility. We looked at the cumulative incidence function of offers for deceased donor transplant, but also took into consideration competing outcomes like removal from the waiting list, sadly mortality on the waiting list, as well as living donor transplants that happened or transplant that happened outside of the province. And finally, we looked at the relative hazard of accessing these offers depending on patient characteristics. So for those who are not familiar with the organ allocation scheme in Quebec, here it is. So we start with a sequence of priorities, and then additionally, there is a score where the score takes into consideration both utility and equity parameters in consideration. So let me start by outlining the priorities. Aligned with what the public was telling us was important, we start with, first of all, we verified that there's ABO compatibility. But thereafter, priority number one for allocation is urgency in requiring the organ transplant. And this is usually adjudicated at a committee level. So there's a special request for allocation in this context. Thereafter, we have the highly sensitized program where patients benefit nationally from organ allocation. Then we have the third priority, combined organ transplants. So because all of these potentially require access either to other organs or organs that might be shared across the country, those priorities were not included in our simulation. Next, I want to focus on the priorities that were included. So pediatric patients, pancreas, kidney, and allocation for kidney only based on Transplant Quebec score. So pediatrics, there's restriction with regards to donor age to be eligible to be allocated to a pediatric patient. And they are priority number 4. Thereafter, pancreas, kidney with restrictions, again, with the age of the donor and the BMI. And finally, the remaining cohort waiting for a kidney only. So there's a score that is derived based on the following parameters. So from an equity perspective, the waiting time is taken into consideration, the patient's CPRA, and in Quebec, because there are extra points that are given in the absence of incompatibility at the antigen level on HLA-DR, there's also, in the context of a candidate being HLA-DR homozygous, there's extra points that they're getting. And this is important. I'll show you the implications of this otherwise. Then there's the issue of utility. So the HLA-DR compatibility is supposed to improve utility. There's extra points that are given based on the age of the recipient as well as the gap in age from the donor. So what we did was we reproduced, again, this organ allocation scheme in a subset of the Transplant Quebec cohort that was provided to us to ensure that we are comparing, so to speak, apples to apples, that we are not increasing the numbers of donors available for, or kidneys rather, because this analysis was done at the level of the candidate and the kidney allocated. We ensured that we studied a subset of 993 kidneys that were allocated in the province of Quebec, or arose from the province of Quebec and was allocated in the province of Quebec to with 1,800 or so, a little under 2,000 candidates that were deemed eligible, starting from 2016 to 2019. Now, of note, we included all of those who were active in 2016 and all of those who were added on the waiting list over time thereafter. So this was a dynamic simulation model that allowed us to consider each donor as they, or donated kidney as it presented, as well as candidates as they were added or removed from the waiting list. So the majority of the patients were more than 45, male, approximately 2/3. A minority were HLA-DR homozygous. You can see the distribution of blood group, the distribution of CPRA. Majority were 0 to 1% PRA, and finally, a majority Caucasian, but quite a diverse representation. Otherwise, you can see that all kidneys were allocated, whether we used the TQ rules or incorporated molecular compatibility. Moving forward, with this allocation, in comparison to the Transplant Quebec score, on the left-hand side, I can show you that there was improved molecular compatibility with 2 or less eplet mismatches at the Leiden class 2. In the context of homozygous HLA-DR, this was accomplished as well. So even though there were more likely or less likely to access compatible donors, we could accomplish that, but the question is at what price? When we incorporated compatibility at the molecular level, you can see, if you look at the HLA-DR row over there, that in the new allocation, the homozygous HLA-DR had decreased access to transplantation, because in our simulation, when incorporating molecular compatibility, we did not provide them these extra points to access transplantation. The allocation currently working at the antigen level and us moving to molecular compatibility. But this is a problem that is solvable, because again, if we were to look at the likelihood of accessing transplantation in the context of heterozygous in comparison to homozygous, currently the allocation, considering this at the antigen level, does not contribute to inequity. When we are disregarding the likely higher number of molecular mismatches that these patients are observed with molecular strategy, the risk of accessing transplantation is diminished, or phrased differently, the likelihood of a heterozygous accessing transplantation is 4-fold higher than the homozygous. But as soon as we incorporate a different threshold to this vulnerable population, where we prioritize them to access kidneys that are compatible to them, so less than the 5 class 2 antibody verified Leiden mismatches, there is reintroduction of equity in their access to transplantation without compromising other patients' groups. So this is what the rightmost column is showing you. So with this, I showed you that better molecular compatibility can be achieved when it is prioritized in organ allocation schemes, that striving for better molecular compatibility could result in inequities in access to transplantation, but we can resolve those inequities by personalizing, so to speak, the thresholds that we implement in an effort to provide access to vulnerable patients. I'm going to have us go through this slide very succinctly. This is another tool that we developed. This is called the Calculated Panel of Incompatible Eplets. And what this tool does, it allows us to inform individual patients as to their likelihood to access blood group and molecularly compatible kidney offers. So in this context, on the left-hand side, the strategy takes into consideration blood group matched. And what we see over here, that we have, if we are tolerant from top to bottom of an increasing number of residual incompatibilities, the access is effectively increasing. On the right-hand side, further in the middle, in those who are still hard to match at the molecular level, we can pursue transplantation with blood group compatible donors. We effectively do this at the context of AB, for example. And to the rightmost hand side, those who are really hard to match, this is where access could further be improved by disregarding the compatibility at the ABO level. Now, not advocating by any means in doing so without appropriate desensitization in advance, but largely the ABO incompatibility is more amenable to that. Moreover, there's opportunities to share organs at a national level or pursuing a living donor transplant. So we are able, with these tools, to inform individuals with regards to their likely to access a molecularly compatible transplant. So to conclude, as we are striving to implement molecular compatibility into organ allocations, we've demonstrated feasibility, at least based on the initial evidence that we have right now. We have tools to inform patients with this regard, and we can integrate these into regional organ allocation schemes. We are looking at a data set called from the Canadian Longitudinal Study on Aging, in which we have HLA typing from across Canada to illustrate whether for a given candidate or groups of candidates from particular provincial registries, one could increase access to transplantations thanks to leveraging national level donors. And finally, also working on tools to make sure that we communicate these possibilities in an effective fashion. I will say, as we are embarking on the era of molecular compatibility, it is important to ensure that we are transparent with regards to the potential challenges or limitations in access to that some might encounter as a consequence, but also in this process, be able to measure them and make sure that we address them. So amongst others, I illustrated to you how actual typing information could allow us to inform individual patients who are vulnerable and potentially diminish that vulnerability by prioritizing them to access transplantation. I want to start by thanking you for your attention and forgiveness for the technical issues I encountered, but also to thank the various members of the Genome Canada Transplant Consortium, the Research Oversight Committee who supported this consortium over the past several years, as well as on the left bottom hand side, the various trainees, HLA laboratory directors, colleagues from across transplant centers and partnering organizations that who allowed us to pursue this work. So thank you so very much and happy to take your questions. Yes, please.
Hi, Ruth. Thank you for this wonderful presentation. It's always wonderful to hear all your work, and it's just so exciting. My question is, we have, this is great work, and we know that I'm fogging up really badly here, so maybe that might be better. And we can see that applet matching might be, a good way of proceeding with allocation and whatnot. My question is for those highly sensitized patients that are 100%ers, which are so hard to match. How do you envision that the applet matching is going to help them? Because we know we're going through new programs, Winning to Cross, and all these, but we have those patients that are 100%. Do you envision that this is going to help them as well, and in what way?
So thank you for this question. Highly pertinent, right? So certainly this is a challenging population to access transplantation full stop, and certainly access transplantation with lower immunological risk. The fact of the matter is that to begin with, identifying a donor for a highly sensitized patient, if one were to look at the molecular compatibility, it's very high, even without striving for molecular compatibility, right? Because we need effectively compatibility eventually at the allele level to avoid these preformed antibodies. When we are adding molecular compatibility, potentially this population could be disadvantaged from one side. But from the other side, there's also, and this is how actually, and you know this, I know you know this. So this is how originally this molecular compatibility was implemented, right, in Eurotransplant, whereby verification of a repertoire of antibody to be to be attributable to molecular incompatibilities with the actual donor allowed one to pursue transplantation with relatively lower risk. So I think that, again, this will not likely be the ultimate solution, but we can certainly use the verification of capacity to explain antibodies at the molecular level, that there is an incompatibility that informs them to potentially increase access. And beyond that, advocating for these patients, again, with regards to expansion of the donor pool. So this is how I would see this playing out for this particular population. May I say one more thing, actually? Because that name can prevent, right, focuses on prevention of that context. So if we are effectively going to prevent people becoming highly sensitized as a consequence of transplantation, and certainly the pediatric population that is likely to need another transplant in their lifetime is less sensitized as a consequence of better compatibility to begin with. Ideally, we strive to ensure the grafts last for the patient's lifetime. Of course, that is another gain. So prevention.